seniors and my dear colleagues. Welcome to our platform Onco Ocean. Today we are moving forward with another topic, rare and special breast cancer cases, male breast, bilateral inflammatory Paget's disease, Phyllodes tumor, in situ prosthesis, leptomeningeal diseases, breast sarcoma, etc. In today's session, I feel honored to invite our speaker, Dr. Surabhi Gupta ma'am. She's a professor in Department of Radiation Oncology, S.N.Medical College, Agra. She has key interest in breast cancer, interstitial brachytherapy. She's a 2 times Best Lady Doctor Award by UP Indian Medical Association. She has approximately 40 research publications as first author in international and national journal. Welcome, ma'am.
Thank you, Dr. Sunashri. Should I start?
Yes, ma'am, you can start.
Yeah, just wait. I'm sharing my screen. It is visible there?
Yes, ma'am.
Okay. It is on full screen now?
Yes, ma'am. Ma'am, you have to maximize it, ma'am.
Maximize. I'm just trying to do this. Yeah. Now it's okay, I think. No?
Yes, ma'am. You're visible.
Okay, so good evening, everyone present here. So my topic is unusual breast malignancy, as already explained topics, what I'm going to cover by Shona Sri. So directly jumping on the first topic, that is the male breast cancer. We know male breast cancer is quite rare. It accounts near about less than 1% of all breast cancer diagnosed worldwide. We can say out of the 99 female, 1 patient says a male breast cancer. Mean diagnosis is 6 to 7 decade. We can say 67 year. If we compare the female mortality with the male mortality breast cancer, we find that male breast cancer mortality is more. It may be due to the reason that these patients present in the very advanced stage because they are not aware about their signs and symptoms. So 15 to 20% of the male breast cancer have a family history of the breast or the ovarian cancer. If we see that in a family, if a female is having the breast cancer, the chance of having male breast cancer in her son is more as compared to her daughter. This is quite surprising thing. We compare with a woman, male breast cancer present in the late stage, larger nodal and larger tumor size, more frequent nodal involvement. Ductal histology is predominant because male breast usually don't have the lobes, so lobular carcinoma doesn't occur there. These are usually estrogen positive tumors. And the most common presentation is the painless lump, especially in the subareolar region. Near about 50% of the patient present with this presentation. Clinical suspect is usually lymph node is defined in 50 to 40% patients. Yeah. So evaluation or extent of disease and stage classification is just like other female breast cancer. So it is not differ from their diagnosis and the TNM staging, same as the female breast cancer. So what are the risk factors for this male breast cancer? Estrogen excess and androgen less. We can say the increased estrogen to androgen ratio is disturbing. Whenever it is disturbing, it is raised, male breast cancer arise. So what are the various conditions where the estrogen level raises? So this may be due to the Klinefelter syndrome. The male is having the obesity, marijuana user, hepatic dysfunction, thyroid disease, and exogenous estrogen medication. These all causes the hyperestrogenism in the body. Apart from this, what are the various factors causing the lower androgen, circulating androgen in the body? The condition are cryptorchidis, orchiectomy, or testis inflammation, yeah, orchitis, we can say. So these are the general risk factors for the male breast cancer. Apart from this, if patient is having the personal history of the carcinoma prostate or family history of female breast cancer, that is more prone of developing the breast cancer. Germinal mutation, especially BRCA2 gene, is a causative agent of this. Apart from this, if that male has been treated for the gynecomastia a long way, though nowadays nobody is using radiotherapy for the treatment of gynecomastia, but in the old time, in the historical time, people were using this. So it has the 7-fold increase in the risk of the male breast cancer. If occupation, though it's not basically proved, but if a male is having a steel or rolling mills worker or involved in the organic solvent like trichloroethylene, then this type of the patient has the more risk of developing breast cancer. Histology, I have already told that these patients don't have the lobular carcinoma, so majority is invasive ductal carcinoma. mostly are ER positive, HER negative tumors. Survival has improved over the time because we are having the more target therapy. We know more about the histology and the molecular behavior of the male breast cancer. But whenever we compare both the things, female and the male breast cancer, we found that these patients usually have the more morbidity and more mortality comparison to female. Diagnostic workup is the same as the female breast cancer. Surgery is quite same: mastectomy, a sentinel lymph node biopsy for the small tumor, and for the larger tumor, mastectomy with axillary nerve dissection. Breast cancer therapy, initially it was not advised for the male breast cancer due to the small breast content, but nowadays surgeons are doing breast conservative surgery with the better cosmetic result. Radiotherapy is the same indication like in the female breast cancer guidelines. And because these patients had the more ER positive tumors, so tamoxifen is the basically a integral part of the treatment in male breast cancer in an adjuvant setting as well as for the metastatic center settings. Usually, these patients are not advised aromatics inhibitors, but if tamoxifen is not working or patient is not a suitable candidate for the tamoxifen, then these AI inhibitors can be given along with the LHRH agonist. Chemotherapy is basically beneficial in case of the high-risk disease or the metastatic setting. Usually, doxorubicin-based chemotherapy is given in these type of the cases. But if the patient is HER2 positive, then tantumab is also advised. There are some recommendation from NCCN for the male breast cancer. That is, first recommendation is that the management of male breast cancer should be as per the guidelines of the female breast cancer. Although there is some biological and a clinical difference between both types of cancer, but management diagnostic part does not change. But NCCN panel recommends that all the male with breast cancer should undergo the genetic testing, especially for the BRCA1 and BRCA2. Historically, male with breast cancer has undergone mastectomy, but nowadays BCS can be advised with a good aesthetic long-term results. And sentinel lymph node biopsy should be performed if the patient are having clinical node negative disease. But if the patient is having clinical node positive, then axillary node dissection is advisable in this subset of the patient. So after the male breast cancer, inflammatory breast cancer. So this is basically a subcategory of the locally advanced breast cancer, which has a unique epidemiology, clinical presentation, and the molecular behavior. If we talk about the incidence, so less than 2% of the breast cancer are inflammatory breast cancer. Now coming to what are the clinical characteristics of this type of the tumor. Hallmark. Number one, it is a very rapid disease onset. Usually this type of patient comes with a history less than 6 months. Skin erythema is the hallmark of this disease. We generally see that more than 1/3 of the skin, breast skin is involved and is erythematous. Patient present with the edema PDD orange due to the superficial lymphatic blockage. Browny breast induration is present. Usually these are the warmth is present, temperature is raised as comparison to the opposite breast, and there's a asymmetrical enlargement of the breast of ipsilateral breast. So these type of the presentation may be associated with the underlying lump or it may be without the lump. So sometimes it may be confused with the breast abscess or some other inflammatory condition. So biopsy can rule out this. Apart from this, what is the pathophysiology? Extensive lymphovascular invasion by the tumor emboli is present, which involve the superficial dermal plexus. Distinct biological entity, high histological grade, high percentage of cells in the S phase, aneuploidy. These are the histological characteristics of this inflammatory breast cancer. This type of tumor does not usually present the ER receptors. They have the high level of P53 EGF, and these are having the underexpression of HER2. So these, if we compare the another T4 disease with this inflammatory disease, so we found that these have the very poor clinical outcome in spite of all the clinical measures. Coming to the management of inflammatory breast cancer, it requires a multidisciplinary approach. So it is advisable whenever you start the treatment of the inflammatory breast cancer, it is better to take the pic of that lesion first, because it may have the further skin grafting or the flap for the surgeon. So before availability of the chemotherapy, prognosis was very, very, very poor. But after the invent of the doxorubicin, now we can talk about the 5-year survival rate in this type of patient. Usually these patients are not a candidate of tantumab as these are having the underexpression of HR2. But if these are having the overexpression, then the tantumab should be advised in this patient. Otherwise, if it is ERPR positive or these are HR2 negative, then 4 cycle of FPC followed by the weekly taxanes is advisable in this type of the subgroups. So all patients should be given neoadjuvant chemotherapy so that primary closure of scan flap of mastectomy can be properly done by the surgeon. Adjuvant radiotherapy is recommended after modified radical mastectomy. BCS is usually not advised in inflammatory breast cancer. The better surgical modality is MRM. We know that these type of the tumors have the very rapid course onset. So due to this rapid developing time, we can say the less doubling time, accelerated hyperfractionation should be offered in this type of the patient. Accelerated hyperfractionation with a total dose of the 51 gray with 1.5 gray per fraction with 2 fraction per day should be given to the chest wall and to the regional lymph nodes with boost to the chest wall dose of 15 gray with 1.5 gray per fraction and 2 fraction per day. After all these invent, we found that the local control is very good in this type of subset, 70 to 80%, and 5-year survival is also 30 to 40%. This is the NCCN guidelines for the inflammatory breast cancer. Just a short review that these patients should be properly worked up and photograph is mandatory before starting in the treatment, and genetic counseling should be done for these patients. If the patient is premenopausal, then fertility counseling should also be done. Bilateral diagnostic mammogram, ultrasound advice, and the thoroughly metastatic workup should be done in this type of the patients. So we should start the neoadjuvant chemotherapy. If we see that there is a response after the neoadjuvant chemotherapy, then patient should be offered the total mastectomy with level 1 or 2 axillary lymph node dissection and radiotherapy to chest wall and comprehensive regional lymph node radiation with inclusion of any undissected axilla, or if we found that any lymph node which are at risk. If we found there's no response of the chemotherapy of the first line chemotherapy, then we have to change the second line or the third line until we get the response. If the patient get the response after surgery done, then after radiotherapy, then patient has been put on the. If the patient has been given the HER2 direct therapy, then patient should be offered the maintenance HER2 therapy tantumab. So this all about the inflammatory breast cancer. I'm not covering the complete surgical management part or the radiotherapy techniques and how much dose should be given, because these already covered in the previous lectures. So I'm just emphasizing on some important point. Now coming to the tumor in situ. So tumor in situ is basically, by definition, is a non-invasive type of the tumor. We see that there are 3 subcategories. One is Paget's disease, which is found in near about less than 5% of the patient. 5th to 6th decade is a common age group of presentation of this type of disease. Second is the lobular carcinoma in situ, which is approximately less than 15%. Usually a premenopausal patient present with this LCIC. And the third one is the DCIS. So treatment basically varies from observation to breast conservative surgery to the mastectomy. So coming first to the lobular carcinoma in situ, we all know that it is corrected by the multicentric breast involvement. Due to the loss of E-cathepsin, loose cohesive epithelial tissues are present. So this is not early diagnosed because this does not form a lumpiness. It does not form a lump. So this is very difficult to diagnose in the screening. Multicentric distribution has been seen in up to 90% of the patient. We can see that bilateral involvement is seen in near about 35 to 59% of the LCIC. These type of the LCICs usually are positive. If these present with a high grade or there is extensive breast involvement, then LCIC may develop into the invasive carcinoma or may change into the ductal carcinoma. About management, if it is pure LCIC, then only close observation with regular clinical physical examination with mammography surveillance, 6 monthly or 1 annually is advisable. But LCIC is associated with either DCIC or it is associated with any invasive component, then management will depend on the which type of the dominant histology is present. If it's DCIC, then management will be according to DCIC. If it is invasive, then guidelines will be as per the invasive carcinoma. So which type of the patients are high risk of developing these invasive carcinoma? If there's a younger age, if patient present with a diffuse high grade type of the SCIC, if patient is having significant family history, so this type of the patient should be offered the bilateral prophylactic mastectomy. Though use of tamoxifen also has been seen to reduce the risk of invasion in 56% of the patients. Coming to the second part of the tumor in situ, that is the DCIC, it requires the coordinated multidisciplinary interaction of the oncologist, radiation oncologist, and the surgeon and the pathologist. So women with multicentric DCIC who is having the extensive or the diffuse DCIC component, having the suspicious microcalcification throughout the breast on this mammography, in whom has been seen that by doing the BCSE, negative margins cannot be achieved, or there will be not acceptable cosmesis after BCS. So these type of the patient should be offered the mastectomy. Axially mapping should be done for the extensive high grade of the DCIC, or if there is an associated palpable mass present. RT should be given after BCS. Boost is usually not recommended, as it has been found in various studies that boost does not increase any survival. NCCN guidelines for DCS is just a small review. The primary treatment is either BCS without lymph node surgery or the total mastectomy with central lymph node biopsy with reconstruction. If BCS is given, then patient should be offered the whole breast radiotherapy with or without boost. As I already told, that boost is usually not recommended in TCIC cases, or patient can be offered the isolated partial breast radiation PBI, or in some candidates which are not in some candidates, RT can be basically omitted. Like if the patient is screen detected, low risk type, grade is 1 to 2, size of the lesion is less than or equal to 2.5 centimeter, if the margin is more than or equal to 3 millimeter. In this type of the subset, post-op radiotherapy after BCS can be avoided. After BCS RT, if the patient is ER positive, then risk reduction therapy in the form of the hormone. If the patient is ER positive, hormone therapy can be offered. If the patient is perimenopausal, then tamoxifen. If patient is the postmenopausal, then tamoxifen or the aromatase inhibitor either can be offered to these patients. Third type of the in situ disease is Paget's disease. Usually these type of the tumor is usually confused with the eczematous lesion. So most of the patient ignore this and take some local applications, so present very late in the clinical for the treatment. Crusting and eczematous change of the nipple areolar complex is the prominent clinical feature of this type of disease. Paget cells are the hallmark of this disease, which are located throughout the epidermis. This is associated with the underlying malignancy. It may be synchronous, it may be the bilateral, or usually males present with the Paget's disease. Male predominance has been seen. So DD, when we talk about this type of disease, so some differential diagnosis which comes in our mind is the superficial spreading melanoma, Pagetized squamous cell carcinoma in situ, or clear cell of Toker, which is basically dermatosis in the children. In more than 19% cases, it has been found that these Paget's disease associated with the invasive carcinoma, and approximately 50% of cases present with the clinical palpable lump. So prognosis, when we talk about the prognosis, it does not depend on Paget's disease itself, it depends on the associated malignancy. Limited surgery and post-op radiotherapy is the optimal management if pure Paget disease is present. NCCN guidelines says that if you are having the clear suspicious of Paget's disease, then do the thoroughly clinical breast examination, diagnostic mammograph or ultrasound if necessary. After examination or imaging, if it is found positive for the breast lesion, after core biopsy, we see that we do the core biopsy of the breast lesion, and the full thickness skin biopsy is advised of the involved nipple areolar complex. If it is negative, then just keep the patient on the follow-up. If we see that this lesion is not healing after the 2 weeks, then do the repeat biopsy. If those breast DCIC is present, then guidelines will be there as per the DCIS management. If breast invasive carcinoma is present, then patient should be treated as the guidelines of the invasive carcinoma. If the breast is negative for the Paget's disease, negative for the cancer but positive for the Paget's disease, then this patient should be considered for the MRI and the tissue sampling. And further offers should be further offer central lumpectomy, including the nipple alveolar complex, followed by the whole breast radiotherapy. Or this patient can be offered the total mastectomy with or without sentinel lymph node biopsy. If the examination is negative for the breast lesion, then full thickness skin biopsy of the involved nipple alveolar complex should be done. If it is found to be positive, then the same guidelines consider the patient for the central lumpectomy. If it is negative for the Paget's disease, then patient should be put on the clinical regular follow-up. So that's about the tumor in situ. Now coming to the another part of presentation, that is the prosthesis. So post-MRM and the reconstruction. This is again the very challenging condition for the radiation oncologists also and for the surgical oncologists and the plastic surgeon also. It requires clear communication between the surgical oncologist, reconstruct plastic surgeon, and the radiation oncologist. And obviously, patient should be included in the treatment decision. So some points should be considered while doing the reconstruction, that it should ensure the safety and efficacy of the radiation treatment. Patient should be offered the maximum quality of life, and quality of life should not be compromised in these type of the measures. Patient should achieve the long-term aesthetic result from this procedure. Reconstruction may be two types. It may be the plant-based or the autologous tissue construction. According to timing, it may be the immediate reconstruction or it may be the delayed reconstruction. So we will talk about first the implant-based prosthesis. This is simpler because no donor site morbidity is there, because donor is not giving the tissue. So it is very simpler procedure. Can be used in the thin woman who does not have the adequate volume for the autologous tissue. It requires the immediate implant after the post-MRM. As radiotherapy, after the radiotherapy, normal tissue are the less compliant for this prosthesis. So it should be done the immediate. Implant should be done immediate post-MRM. Second type of the reconstruction is the autologous tissue or reconstruction. It can be either immediate or delayed after radiotherapy. Immediate reconstruction has its own benefit, like skin sparing mastectomy can be done, or optimal cosmetic outcome can be achieved after the immediate reconstruction. So what are the challenges? Challenges are effect of radiation on the reconstruction. Majority of patients who undergo immediate reconstruction and require the post-MRT will have the aesthetic change as a consequence of the treatment. These changes usually begin 6 months after the radiotherapy and it progress over the time. These challenges are the late contraction of the implant, fibrosis may be there, implant fixation may be there, which ultimately leads to the poor aesthetic outcome of the patient. Immediate reconstruction have the high rate of complication as compared to delayed reconstruction. But again, the very debatable point. The second is the effect of radiation, effect of reconstruction on the radiation treatment. Reconstruction affect the contour of the chest wall. So again, it poses a very challenge to the radiation oncologist for the proper tumor coverage and the how to deliver the radiation appropriately to the patients. Because overinflated tissue can cause the slight sloping of the contour. So radiation, we have to be very vigilant while planning of these type of the patient, so that neither the overdose or neither underdose should be received. Now coming to the breast sarcoma, the another part of presentation. Breast sarcoma is usually rare type of the tumors in breast. It is an aggressive malignancy. It arises in non-epithelial tissue like connective tissue within the breast. They account of less than 1% of the all breast cancer. And if we talk about the soft tissue sarcoma, so it constitutes less than 5% of the all soft tissue sarcomas. It can be primary if it arises de novo. If this breast sarcoma arises after the breast irradiation to the chest wall or in the setting of the chronic lymphedema, then it is called the secondary sarcoma. Sarcoma is a very wide subcategory: angiosarcoma, fibrosarcoma, liposarcoma, leiomyosarcoma, and differentiated below sarcoma, and other sarcomas include the rhabdosarcoma, malignant phylloid sarcomas with bone or cartilage component. But management of sarcomas are near about same. So I'm not going to discuss one by one. I'm giving a overview of these sarcomas. So breast sarcoma often grow rapidly and have a high risk of recurrence and metastasis compared to breast sarcomas. They typically presented a rapidly enlarging breast mass, which may be palpable, have the skin change like discoloration because these presented a huge mass, so stretching of skin is there. Due to its rarity and potential of rapid growth, breast sarcoma can be challenging to diagnose using the conventional breast imaging, mammography, sonography. So MRI usually advised in this type of the patient. Core biopsies often prefer diagnostic modality to rule out the epithelial or non-epithelial type. Surgical management is often wide local excision, either in the form of the BCS, if possible, or total mastectomy, if the last tumor is there, if we found that BCS does not giving the good cosmetic result. If in case of the radiation-associated breast angiosarcoma, this type of patient usually require the total mastectomy with radical excision of the radiotherapy treated skin. Breast sarcoma have the hematogenous spread, so lymph node evaluation usually not a part of the staging and neither a part of the treatment modality. Local recurrence rate is usually high. Prognosis remains very poor, though ongoing advances are going on. Breast sarcoma has the poor prognosis than the sarcomas due to the high risk of the recurrence and the high metastatic chances in these cases. So to summarize the surgical management of this sarcoma, phylloid is usually 3 types. I will discuss on later slides. So coming to the angiosarcoma, primary modality treatment, if there's a primary angiosarcoma, then mastectomy, which is a radiation induced, then mastectomy along with the resection of all its skin should be done. If it is desmoid type, then excision up to the negative margin of other histology type, then again the same excision to the negative margin should be done. These are different as emphasizing the role of adjuvant radiotherapy after the surgery. So it has been seen that in case of the patient is having after surgery having the positive margin, if the tumor size is large, then this patient should be offered the adjuvant radiotherapy. Coming to the phylloid tumor, this is, I have already discussed that this is a type of the soft tissue sarcoma. Phylloid tumor breast is relatively rare fibroepithelial neoplasm that present a morphologic continuum from the benign to malignant. Most phylloid tumors behave benignly with local recurrence occurring in a small proportion of the cases. Very rarely, these tumors may metastasize. Phylloid tumors exhibit an enhanced intracanicular growth pattern with leaf-like projection, so it is called the phylloid. Name arisen from here. Into the variable dilated elongated lumina. The epithelial component consists of lumen epithelium and myoepithelial cell staged into arc-like cleft. Clinical phylloid tumor usually confused with other type of the benign lesion. Like in case of the benign phylloid, it may be get confused with the fibroadenoma. In case of the borderline of the malignant phylloid tumor, its radiological may be confused with the soft tissue sarcoma. It mass may be present usually 1 to 45 centimeter. We have seen many cases of the phylloid tumor patient presenting with a huge mass involving all the quadrant of the breast. So this is the common presentation in our OPDs. Management, complete wide local excision with greater than 1 centimeter margin, often curative and reduce the risk of local recurrence in usually benign and borderline type of the phylloid tumors. Large tumor require a mastectomy. Because there's no use of doing the BCS, we are not getting the good cosmetic result in large tumors. Despite the high incidence of the local recurrence secondary to BCS, study has shown no difference between the BCS surgery and the mastectomy in these type of the subset, but in large tumors, still the MRM should be done. Prognosis of phylloid tumor is good with 10-year survival in 87% of the case. And recurrence risk varies with the tumor size. The larger tumor size, then the recurrence is more. And what type of surgical approach you have used for the treatment. Suppose a patient had been treated previously with the wild local excision, but not the negative margin were positive, then this type of the patient usually comes with the recurrence. Very rarely the tumor may metastasize, most commonly in the malignant variant of the phylloid tumor. And this carries a very poor prognosis. This is NCCN guidelines for the phylloid tumor. Just to give, to summarize the thing, that if the intermediate or suspicious of the benign phylloid, just do the excision biopsy. If the fibroadenoma, keep the patient on the observation. If the benign phylloid, just excision biopsy with clear margins is sufficient. Clinical follow-up for the 3 years should be, patient would be on the follow-up. Phylloid, if these are the borderline or malignant, it is found that wide local excision with clear margin should be done. If the malignant use phylloid tumor is, then modified, then mastectomy should be offered in this type of patient. Axillary, because these does not present with the axillary lymph node, so axillary staging or the axillary dissection is not advisable in phylloid tumors. Now coming to the another part of presentation, that is bilateral breast disease. Again, this is very uncommon presentation. Only 1 to 3% of the all breast carcinoma patient present with a bilateral breast cancer. So we have to first of all realize that whether it is synchronous, whether it is metachronous. If the secondary breast cancer arise within the 3 to 6 month duration of the first one, then it is called the synchronous bilateral breast cancer. If it is arise after the 6 months, then this is called the metachronous breast cancer. Because of low incidence, relevant literature is less regarding the clinical pathological profile and the treatment profile and the outcome of the bilateral breast cancer. Usually younger, these type of the patient present in younger age. These patients have a strong family predisposition. These are usually BRCA1 positive, BRCA2 positive patients. These have the multicentrity or the lobular type of the breast carcinoma associated with bilateral presentation. So the important challenge in the management of bilateral breast cancer is to diagnose whether this is the secondary primary tumor or this is the metastatic from the already existing tumor. So detailed histological type, like degree of differentiation, presence of the in situ component is there, then it indicate that this is maybe the second primary tumor, not metastatic. So surgery may be offered depending on the which type of tumor. If patient, suppose one breast tumor is T4 tumor, the another is T2 tumor, then T4 tumor should be given the more emphasis for the treatment. So guidelines should be according to higher grade or the higher tumor size of the tumor, high stage type of the tumor. So surgery in the form of the bilateral mastectomy can be offered, or patient may be offered the bilateral breast conservative if the lower stage early breast cancer, or one breast may be offered the MRM and another breast may be offered the BCS depending on the presenting scenario of these patients. So for a woman with a bilateral breast cancer with indication of post-medical radiation or radiation as a component BCS, sparing the heart and lung with broad field sufficient to cover the entire chest wall can be daunting. It is really very challenging for a radiation oncologist to irradiate both the breast. So many times radiation oncologists prefer for MRM, unilateral, one side MRM, other side of the BCS, so that opposite side of radiation can be avoided. But in condition where the bilateral breast radiation can be done, yeah, it can be done with the latest technology. It has been seen that the 3D CRT or IMRT, VMRT, though it is achieved the very good tumor dose algorithm, but OAR constantly usually not exceed with these type of the technique. So proton beam therapy can be a good option for these type of the patient require the bilateral breast irradiation. So to summarize this is the rare clinical scenario. It poses a challenge to the oncologist regarding the selection of the treatment modality. Routine bilateral mammography should be offered to the patients, high-risk patient for any breast lump, so that this bilateral breast cancer can be detected early. A meticulous work of both the lesions separately should be staged. Histology should be done. Receptor status of both the breast lesions should be done separately. Breast conservative surgery equally effective as mastectomy according to treatment outcome. Mastectomy can help to avoid the adjuvant radiotherapy in early stage breast cancer. So discordance in stage, grade, and receptor status is important for the prognostication. Adjuvant chemotherapy, radiation, hormone therapy is indicated according to individual stage and risk features in the post-operative HP reports. Now coming to the last part of my presentation, that is leptomeningeal carcinomatosis. This is a very rare complication of the breast carcinoma, where cancer cell is spread to leptomeninges. This is the thin layers of the tissue covering the brain as well as spinal cord. It is a very serious condition. If it not diagnosed early, it may be very fatal condition. And breast cancer is the most common cause of the leptomeningeal carcinomatosis. The prognosis of patient with MC is generally poor, with median survival only, I think, 4 to 6 months, not more than 6 months. Leptomeningeal carcinomatosis is defined, if we define this, is the infiltration by the cancer cells of the pia mater, arachnoid matter, and the subarachnoid space. All the breast cancer is the tumor, which is the most commonly associated with leptomeningeal disease due to its high prevalence, but LC remains a rare manifestation, occurring in up to only 5% of the patient with breast cancer. However, it is characterized by the severe impact on the morbidity and mortality and carries a very dismal prognosis in spite of all the multimodality aggressive treatment approach. It is estimated to affect 8% of patients with systemic cancer. Robust evidence guiding treatment management is lacking because of the rare presentation. No guideline is there. So all the suggestions are according to the review of literature or some case studies or case reports. Combining systemic and the intrathecal therapy may optimize the outcome in patient. Though the prospective randomized trial with the centralized LMD criteria and response assessment are needed to comment on the proper treatment recommendation of this type of the cancer. Intrinsic subtype most commonly triple negative breast cancer present with leptomeningeal disease, and it is estimated that approximately 40% of the total patient who develop metastasis at this site have the triple negative primary tumor. LC may manifest a variety of symptoms with the multifocal involvement of CNS. Finding may be subtle, non-specific initial phases. So these usually present in the very late stage. Whenever these are symptoms, these are headache, vomiting, nausea, neurocognitive deficit, gait abnormality may be present. Patient may present with a cranial palsy, hearing loss, visual disturbance, seizures, dizziness, radical signs including pain, weakness, cardiac venous syndrome. So it depends on the site of the middle side of the involvement. Uncommon presentation may be the newly diagnosed psychiatric disorder. Rare clinical picture may be the central fever or diabetes insipidus. It has been seen in a few cases. In minority of cases, LC may be diagnosed incidentally in asymptomatic patients. So LC can be very difficult to diagnose early, presenting with elusive clinical and radiologic finding. Currently, there is no consensus in diagnosis, but this type of the patient require the combination of neurologic assessment, clinical history, nerve examination, imaging, contrast analysis, MRI, and CSF analysis. These are the diagnostic tools which should be used for the leptomeningeal carcinomatosis. Imaging crucial for the initial LC assessment. MRI of the entire neuroaxis is advisable, and CSF analysis is the gold standard of the diagnosis. ECMO guidance suggests that CSF cytology can be considered positive if the malignant cells are formed in the CSF, equivocal if there are atypical cells in the sample, or negative if they are totally absent. These are the chemotherapy basically which can be given intrathecal or the systemically therapy. So when we talk about the management of the leptomeningeal carcinomatosis, it may be the surgical, but surgical dose is very less. If the patient present with the intracranial tension, high intracranial tension, then VPSN can be advised. If the usually standard gold treatment is the intrathecal methotrexate or the cytarabine thiotepa. Nowadays, immunotherapy also is advised. Tumor infiltrating lymphocyte also currently in research for the leptomeningeal carcinomatosis. If patient is given the radiotherapy, the whole brain radiotherapy is advisable in these type of patient. If systemic chemotherapy or intrathecal chemotherapy does not improve the signs and symptoms of this type of the subset of the patient. So this all about the presentation. I think I have covered broadly all the aspects. So thank you so much for patience listening.
Thank you so much, ma'am. That was a wonderful session. I request all the participants to please kindly post their questions in the chat box. Ma'am, we have one question from Dr. Aditya. Ma'am,
Yeah.
what should be done in metachronous bilateral breast cancer when second tumor has different IHC status from the first one?
Yeah, I have previously said that these type of patients should be basically treatment decision should be on the advanced, which type of the, in which tumor is having the advanced disease. Yeah, I told that the one breast is having the T4, another is T2. Then emphasis should be given the histopathology characteristic of the T4 type of tumor.
Thank you, ma'am. I don't see any more messages in the chat box. Ma'am, can you explain the guideline of treatment with intrathecal methotrexate?
SS guideline is not there. I have told that there is no such guidelines, but intrathecal cytarabine and intrathecal methotrexate is used by many clinicians, and they found the good result in this. Nowadays, immunotherapy, people are using intrathecal immunotherapy also, but there is no such guidelines for the specific for the leptomeningeal carcinomatosis specific to the breast cancer. This is generalized guidelines.
Ma'am, we have another question. In phyllodes tumor, adjuvant RT reduces recurrences in both BCS and mastectomy, or is there any difference of recurrence in both of them?
Basically, recurrence depends on the previous surgery type, which I've been told. So mastectomy, after mastectomy, recurrence is very less. But in case of the BCS, if after BCS margins is not clear, then these patients have the more chance of the recurrence. This is generally says that the patient is having the benign type of phylloid, recurrence is usually 10 to 17%. If there is the borderline of the phylloid, then recurrence is usually 14 to 25%. If it is a malignant type of the phylloid, then the recurrence is 23 to 30%. So it depends on histopathological type of the phylloid. The second thing, these type of the patients require the adjuvant radiotherapy. The tumors is more in size, more than 5 centimeter. If margin is positive or patient presented with the recurrence, adjuvant chemotherapy is not advisable in case of the phylloid tumor. But if Ki67 is high, proliferant index is high, then they should be provided a chemotherapy. Or in case of the metastatic setting, which usually rarely present, then chemotherapy should be given as per the soft tissue sarcoma guideline.
Ma'am, in resource limiting setup, usually patients are non-compliant with intrathecal methotrexate. Then what is the role of whole brain RT in these patients?
Yeah, you can give. I told them, if the patient is not basically candidate for the systemic chemotherapy or intrathecal chemotherapy, then whole brain radiotherapy can be given.
Thank you, ma'am. Thank you so much. Thank you so much, ma'am. Now we come to the end of this session. Ma'am, I would like to thank you for taking out your valuable time and sharing with us your insightful presentation. Thank you so much, ma'am.
Thank you, Shonashri, and thank you, Dr. Ankita, for giving this opportunity. Thank you, everyone.
Thank you, ma'am.